Uh, Sunil sir, should we start? Like,
I'm ready.
yeah, we are live on YouTube also. Okay.
Just
Uh, so I'll go on with the introduction by the time you fix it.
sure, and I'm ready.
Good. So good evening to one and all present here. Welcome to the academic platform Onco Ocean. This is the platform curated for the residents of MD and DNB curriculum, covering various topics which are asked in their exams. Today, here we are with yet another interesting topic, rather a practical topic which we usually deal in our clinical practice. That is breast cancer management in elderly patients. For today's talk, I feel honored to welcome our chairperson, Dr. Sunil Choudhary sir. He's done MD radiotherapy and he's currently professor and head of department of radiotherapy and radiation medicine in IMS BHU. He has a working experience of almost 18 years and teaching experience of 16 years. He has done AROI fellowship for abroad in 2019. He has been a thesis guide for many topics and currently supervising various thesis topics. A comparison of concurrent chemoradiation with 6 fractions per week of radiotherapy versus conventional CTRT in patients of carcinoma cervix, completed in 2015. A comparison of intracavitary with interstitial brachytherapy in locally advanced cervical cancer. Comparison of intracavitary with interstitial brachytherapy in locally advanced cervical cancer. Welcome, sir.
Thank you, Aditya. And at the outset, I would like to thank Dr. Ankita and the team for giving me this opportunity to come to this platform and interact with the students. And I also thank Dr. Ankita for bearing with me for allowing me to postponing my sessions for a long period. So let's start. Sorry for the glitch. So the meta-analysis, which was published in Lancet 2011 by Early Breast Cancer Trials Group, it was done on patients who had BCS, and there were 17 RCTs included in this trial, and more than 10,000 patients, where whole breast was compared with no RT. And if you see this, move to the next slide, please. So if you see this Kaplan-Meier plot on the left side, you can see the arrow. So if you see, there was a 10-year gain of 15.7% with when RT was given after BCS. See the difference of if it was only BCS, it was 35%, and if RT was added, it's around 19% in any time recurrence. And there was a modest increase in survival by about 4%, 3.8% with the addition of RT. And if you see overall survival, overall death, the difference was slightly less. But if you compare patients who had node positive disease with patients who had node negative disease, node negative with node positive, the difference was the benefit of RT was still there. Almost it was regardless of node positivity. Can we move to the next slide? Aditya? Aditya, can you move to the next slide, please? Yes. So on a subset analysis, if you see, when they studied the several prognostic factors, and you see the age, so patients who were 70 years and plus, the advantage with RT after BCS was minimal compared to patients if you go from 70 to 60 to 69 and then further on to less than 40 years. The advantage was maximum when the patients were young, and patients were elderly. The advantage of adding RT after BCS was quite less, though significant. Same for tumor grade. Patients who had high grade, the advantage was more. Patients with low grade tumors, the advantage was less. Same for the size. For T2 disease, the advantage is more compared to patients who had a T1 disease. And patients who had ER positive disease, the advantage was more. And if you see ER without tamoxifen and ER positive with tamoxifen, when tamoxifen was given, the advantage was less. Go to the next slide, please. So I want to suggest that breast is a heterogeneous disease. It's not a single entity. It's a mixed bag of several diseases inside. Next slide, please. So one size doesn't fit all. We have to understand that there will be patients with a particular treatment. There would be a group of patients who would benefit a significant amount. There would be patients where the effect won't be there at all, and there would be patients who will have, instead of benefits, there would be adverse effects. So we need to choose our treatment very optimally. Next slide, please. Next slide. Next. So there are several factors which decide our treatment. The factors may be related to the patients. Young patients, they do bad compared to patients who are elderly. Tumor, the tumor size, the tumor grade, tumor histology. Like we should ask our pathologist to give us the histology. Patients who are having pure tubular or pure mucinous or pure, there are few variants which have a very good prognosis, like pure cribriform or encapsulated papillary or solid papillary. These patients will have a good prognosis. And the treatment, of course, is the treatment which affects the survival. And there are several genomic markers. We all know about BRCA. We all know about Ki67. There's so many other markers, PDL1. So these are they are prognostic as well as predictive factors. There are few factors like ER positive, which are both ER receptors, which are both prognostic as well as predictive. So we should understand that we have to integrate factors related to the patient's tumor in treatment. Apart from them, the genomic biomarkers should be also taken into account. And as Aditya told me, there will be a speaker who will be talking about artificial intelligence. With this artificial intelligence, we can improve the screening, reduce the false negativity or the false positivity rate. We can improve the diagnostic part. We can collaborate or integrate all the findings to suggest what should be the proper treatment to the patient. Next slide, please. So, like the standard, go back, please. The standard was to give radiotherapy, or initially we started with the whole breast a mastectomy, then we confined to a modified radical mastectomy, and then we went down to a BCS. Same for radiotherapy. Initially, we went for a whole breast radiotherapy and treated the draining lymph nodes in almost all the patients, and then we coned down to a partial breast, and then we are talking of omission of radiotherapy. Many times you omit giving radiotherapy to the draining nose as well. Next slide, please. Next slide. So my topic is to talk about de-escalating radiotherapy in elderly. So we should know what is an elderly patient. So the cutoff for the cutoff age is not well defined. If you see NCCN, it says 65. If you see other European Society of Breast Cancer Specialists or this, they say it's around 70 years. But if you see the literature, most of us, the literature, they talk about 50 years and plus as elderly. So there's a distinct, like the 50 years and above, there's a distinct, like you can completely appreciate the change in the prognosis and everything after beyond 50 years of age. Next slide, please. So over-treating our patients, it has a cost to the patient. Like there would be unnecessary treatment toxicities, financial cost is involved, there's loss of precious time. Unnecessarily, the patients will be coming for the treatment for a 5 weeks period or 3 weeks period, and there are logistic challenges. Next slide, please. Since I'm a radiation oncologist, I'll not involve myself talking about chemotherapy or something else. I'll indulge myself with radiotherapy. Next slide. So focus on radiotherapy and talk about, next slide, please, and talk about, yes, and talk about radiotherapy, de-escalating radiotherapy in elderly only after BCS in early breast cancer. So the roadmap would be, can we do away with tumor bed boost? Can partial breast reduction be enough, or can we omit radiotherapy altogether? Next slide, please. Next slide. So this was a landmark trial by Bartenging et al., which is published in Lancet Oncology 2014. And this trial compared boost versus no boost after BCS in early breast cancers, all stage 1, stage 2. After complete excision, patients who had a positive margin were excluded. Exit dissection was allowed, and the dose, which was external RT, which was given, was 50 grain 25 fractions over a period of 5 weeks. And the patients were randomized to no boost, tumor bed boost, and tumor bed boost to a dose of 16 grain 8 fractions over a period of 1.5 weeks with electrons. Next slide, please. And this is a 20 years follow-up. It's a significant long period of follow-up. Next
So
slide.
sorry to interrupt you again. Actually, in a minute, the Zoom meeting time will end. So I'll be like sharing this Zoom again, like with the same ID only we can join it back.
Okay.
Like I guess there's 1 minute you can talk.
Okay, next slide, please. So if you see the demographic profile of the patients, most of these patients, around 60% patients were elderly, beyond 51 years, 50 years and above. 60% were postmenopausal ladies, and just 20% were had an N1 to N2 disease, and about 50% patients had hormone receptor positive disease. Next slide. So if you see this Kaplan-Meier, and even at 20 years, there was a difference in the epsilon breast recurrence. The tune of like at 10 years, patients who with no boost, it was 10.2%, and with boost, it was 6.4%, a difference, absolute difference of around 4%. Same was the case at 20 years. So the graph kept separated even at 20 years. But if you see the survival rate, OS, there was no difference even at 20 years. Next slide, please. Next slide, please, Aditya.
Yeah.
See, the earlier we used to give 15-25 over a period of 5 weeks, and then we moved to moderate hypofraction, and now we are moving to ultra hypofractionation. So moderate hypofraction has become the standard, 40 grain 15 fractions over a period of 3 weeks, or 39-13, or 42.5 in 15 fractions, or 13 fractions. This is the standard now. So if we are practicing this moderate hypofractionation or ultra hypofractionation, do we need to really boost the tumor bed? Next slide, please. So if we see this table, so these are the landmark trials which compared hypo with conventional FIFT, like this was start A, and then start B and OCOG in the fast and the fast forward. These were the ultra hypofractionation. So if you see start A, the median age was 57 years. For start B, the median age was also 57. The fast, it was 63 years, and then the fast forward to 61 years. So all these patients were beyond more than 50 years. And if you see the start A, about 60% of patients had received boost, while about 40% didn't receive boost. Same for almost 50% of the patients in start B received boost, and the rest didn't receive the boost. Boost was not given for Ontario group, and neither it was given for the fast trial. And if you see the fast forward, around 75% of patients did not receive boost. And these were non-inferiority trials where all these trials concluded that hypofractionation or ultra hypofractionation was as good as conventional fraction of 50 grain 25 fractions. So with these fractionation where almost half of the patients or no patients were given boost, there was no difference in the outcome. So this next slide, please. So we can conclude that elderly patients, like most of these patients in most of these trials, patients, the median age was more beyond 50 years, and boost was not given most of these patients, almost half of the patients. So though we don't have a direct evidence, but from this we can extrapolate that boost can be safely avoided in patients, elderly patients when we are practicing moderate or ultra hyperfractionation radiotherapy. Next slide, please. Now, whether to give a whole breast radiotherapy or partial breast irradiation can be done in elderly patients. Next. So this was a meta-analysis published in the Red Journal in 2022. Next slide, please. So they compiled different studies, and the technique of giving boost the technique of doing this partial breast irradiation was different in this study. The patients who had external beam without CT planning, the patients where the partial breast irradiation was done using brachytherapy, and there are patients who had intraoperative radiotherapy, and there are several studies where patients had this APBI done with EBRT with CT planning. Next slide, please. So there were 4 groups, and these, like if you see, this is for PBI partial breast irradiation, and this table is for the whole breast irradiation. Like the different dose schedules, all to the tumor bed, the APBI, and if you see this, this was one of the important trial, the import load trial, where the tumor bed with a margin of 1.5 centimeter was treated, and a PT margin of 1 centimeter was given. Dose was 40 grain 15 fraction over 3 weeks with PBI, and with whole breast the dose remained the same. Next slide, please. If you see this forest plot suggests that this side is PBI is worse and this side is PBI, and the partial breast is better. This suggests that overall it was in favor of, well, it was against PBI. So PBI is worst if it was practiced. But on a subset analysis where these patients, these studies which where external beam RT was used without CT planning and intra-op brachytherapy were removed, and they studied just patients who had PBI with brachytherapy or EBRT with CT planning. There was no difference in whether it was PBI or the whole breast irradiation. See, this diamond is touching this line of null effect. Next slide, please. And they also saw if PBI, they also compared the late effects and the acute effects, and they saw that it was like the few things which were against PBI, like absolute breast event and elsewhere recurrence were higher with PBI, but overall the cosmesis was not. Both of these were comparable. Next slide. So I would suggest that it's a wide selection of patients is needed. You need to select your patients very wisely. It has to be a highly selective group of patients, very early stage, and the right technique for APBI needs to be used. It has to be CT-based planning. Brachytherapy can be used. We do it usually with brachytherapy, most of the patients. Go to the back. Previous slide, please. Okay, next slide, please. Sorry. Now we are over with APBI. Now let's see if omission can be done. So this was a CalGB. This is landmark trial, CalGB 9343. Most of the studies are the suggestions are recommendations based on this CalGB 9343 trial. And if you see most of these patients were very highly selective patients, 70 years, T1N0, knowing all negative margins, ER positive, patients had lumpectomy, ALND was not mandatory, and a good follow-up around 13 years. And the patients compared randomized in two arms, tamoxifen alone or tamoxifen with whole breast radiotherapy and tumor bed boost. Next slide, please. You see there's a difference in the local original recurrence-free survival. It was in favor of patients who had tamoxifen with radiotherapy compared to patients who had only tamoxifen, to a tune of 8%. But there's no difference in distant metastasis-free survival of the OS. Next slide, please. Mastectomy-free survival remains the same, whether patients receive tamoxifen alone or RT with tamoxifen. Next slide, please. Another landmark trial by which was published in NEGM, Prime 2 trial. After BCS, patients more than 65 years, T1, T2, less than 3 centimeters, N0, M0, ER positive, BCS with more than, earlier it was just BCS, lumpectomy with clear margin. Now they took patients who had BCS with more than or equal to 1 mm margin, and they were eligible if they had LBI neck. If both of these were positive, they were not included. And the patients are randomized into tamoxifen alone or tamoxifen with whole breast and boost, and a good follow-up around 9 years. Next slide, please. Again, there was difference in the local recurrence-free survival in favor of patients who had RT. Patients with RT had a recurrence rate of just 0.9%, while patients who had no RT, it was 9.5%. So if you see, the plot suggests that patients should receive RT, even in a very selective group. But there was no difference in OS or the DFS. Next slide, please. They did a post-hoc analysis to explore the effect of estrogen. Patients who had high estrogen, if you see, and they defined it with an Alred score of 7 to 8 or ER active, estrogen is at least 20 F mole per milligram of protein or ER more than 50%. And you see, patient at 10 years, patients who had high ER positivity and radiotherapy, the incidence of local recurrence was 1%. Was 1%. Of patients ER with no RT, it was 8.6%. Patients with ER low, it was 0, and ER low with no RT, it was 19.1%. So it suggests that patients who are low ER positive, the chance of recurrence was high. So patients who had high ER positivity, and if RT was given, the chance of recurrence was very low. Next slide, please. Another important Lumina 8 trial, which is again published in NEGM 2023. Earlier, patients were above 65. In this trial, patients who were more than 55 years, T1N0, grade 1 to 2, LBI negative, EIC negative, Lumina A, ER more than 1%, PR 20% and above, HER2 negative, and Ki16 less than, defined as less than 13.25%, BCS with a margin of more than 1 mm. It was a single-arm prospective study, 500 patients. RT was omitted in all the patients. Patients were given either tamoxifen or AI for 5 years. Next slide. And if you see, with tamoxifen or AI for 5 years, the probability of local recurrence was 2.3%, quite low. Next slide. So despite selecting a highly selective group of patients, very low, like age more than 55 years, ER positive, high ER positivity rate, luminal A, negative margin of more than 1 mm, there was a recurrence rate was high when RT was omitted. So can we add something so as to select our patients more judiciously? Next slide, please. So if we integrate the genetic signature assay, probably we will be selecting our patients in a better way. Next slide, please. So there was this is a 5 years outcome IDEA study where you see they included oncotype DX and patients who had a risk score of less than or equal to 18, they were included in this group. So patients from aged 50 to 69 years, P1 pathology T1N0 margins more than now it's more than 2 mm, ER positive, PR positive, HER2 new, and it was single arm prospective study, 200 patients, good follow 5 years. Next slide. And if you see freedom from recurrence, estimate was 5-year freedom from any recurrence was 99%. So if you take oncotype DX into account and with a recurrence score of less than 18 or less, chance of recurrence, if you select those patients, go to the previous slide, please. So if you select your patients very nicely, like 50 years and above, T1, margin, good margin of 2 mm, it's not just no income margin, 2 mm margin or beyond has to be ER positive. If you choose patients who have high estrogen receptors positivity, PR positive, if both of these are positive, the response rate is better with AI or tamoxifen. And HER2 negative, it has to be HER2 negative. Next slide, please. The recurrence rate. See, this is this was for follow-up of around 5 years. But even if you see for at 6 years, it was almost the same. Next slide, please. There are other trials which are trying to evaluate de-escalation in low risk breast cancer patients. We already saw the IDEA trial, and these trials are still going on and the results are still awaited. Probably we will get the results very soon and come to a real conclusion where RT for a highly selective group of patients can be omitted. There's a risk involved with it. We know that we have seen the results of these trials, Lumina A and the Prime 2 trial and the CalGB. With omission of radiotherapy, the chance of recurrence increases, but it doesn't affect the OS or the distant disease-free survival. And the mastectomy-free survival difference is not there at all. Next slide, please. So omission of radiotherapy is safe for highly selective group of patients. And if we integrate genomics like oncotype DX with clinical pathological factors, we would be able to select these group of patients and avoid the recurrence. Next slide, please. So we need to take calculated risk. We cannot, like, we will be over treating most of our patients if we give whole breast radiotherapy or even a partial breast radiation. Next slide. Now, whether we should practice hypofractionated, moderate hypofractionated, or ultra hypofractionated in elderly patients. Few slides on that. Next, please. This was a famous fast forward trial which was published recently in Lancet 2020 by Brunt et al. they compared 40 grade 15 fractions over 3 weeks with 27.5 in 1 week, and the other arm was 26 grade 5 fractions in 1 week. Early disease patients, T1 to T3, N0 and 1, M0. Most of these patients were quite early, and N0 patients. And EBRT was followed by tumor bed boost. In 75% of patients, tumor bed boost was not given, as I had shown you earlier. Next slide, please. If you see this, there's no difference in terms of absolute breast tumor recurrence, relapse rate, or local regional relapse or distant relapse, or any sort of breast. Sorry,
Yeah.
lots of glitches today.
Yeah.
Next slide. So these were like, this was an editorial by Dr. Anusil Munshi, and he correctly pointed out most of these patients were BCS. Like they had included patients who had BCS as well as MRM, and if you see, most of these patients were BCS. And lymph node irradiation, original lymph node irradiation was not addressed. Most of these were 70% had T1 disease, though they tried to include even T3 disease, and tumor bed was given just 25%. 10 years update is awaited. We know that breast, they have behaved like a late tissue, and if we really want to see or appreciate the late toxicity, we need to wait for at least 10 years. And the they had nodal sub study, and the result is still awaited. Can we go to the next slide? So to address this, we have an Indian study which is ongoing, and it's being done by TMC Kolkata, and SGPGI is part of it. And they would be coming up with the answers uh, to the questions which were not being addressed by correctly by the fast forward trial. Next slide, please. So ultra hypofractionated radiotherapy is non-inferior to standard hypofractionated. Now we know that that's this 40 gray or 3913 or 42.5 is the standard now after BCS for early disease. So, but there's a small increase, significant increase in resting duration in edema with when we are practicing hypofractionated. So ultra hypofractionated radiotherapy without boost to the tumor bed can be safely done in elderly patients with a small increase in resting duration and edema. Next slide, please. So I would like to conclude that breast cancer is a heterogeneous disease. Next slide. It's a mixed bag of diseases, and one size doesn't fit all. We have to customize the treatment for our patients. Next slide, please. And we need to integrate everything. Like we need to integrate the factors which affect the prognosis, like the tumor, patient-related factors, the tumor treatment, and the genomic assay should be done if wherever possible, so as to select our patients in a more prudent way, so as to reduce the chance of recurrence. We know that omission therapies can be detrimental if the selection of the patients is not done properly. Next slide, please. I think that is the last slide. So I would say that reiterate that less is the new mode. If we choose our patients in a prudent way, it's very important. Selection of patients is very important. Integration of all the findings, all the important factors which affect the prognosis, or like we have to use the predictive factors to select our patients, and with less treatment we can offer more. Thank you. I would be happy to take questions if there are any. And sorry for the
That was a wonderful presentation, sir. Thanks a lot. And I request all the participants to ask their questions in the chat box. We'll take up. So far, there are no questions, sir.
Good. I think they have understood everything or they haven't understood anything. See, when patients are referred to me, what I do, I don't like the surgeons will always want you to give treatment to all your patients, but it's important that you select your patients properly. Over treatment is not a good way. I mean, giving it's very easy to treat each and every patient with all the modalities you have, but choosing the right thing for the right patient is very important. So I always reiterate to my students, keep on telling them that it's very important to select your patients very nicely, integrate all the things, look into your file, look into the record of every record the patient has, the clinical and everything, the surgical record and everything. And because the patient need to be treated only once, like if you make a misjudgment, if you overtreat or undertreat, that will and the patient has to pay for it very heavily. The disease, chance of recurrence, or the side effects, everything is involved, and the patients are the sufferer. So it's important to select your patients and give the right treatment to your patients.
There are no questions yet. Sir, I have a question. Like in hormone positive metastatic breast cancers, now the recent like we have de-escalated from palliative chemotherapy to hormone drugs like palbociclib, fulvestrant, and all. What is your take on it? Like, are they equally effective?
I didn't get it. Like just saying, what are you trying to ask? Like, can you just
Like earlier, for metastatic cancer patients with hormone receptor positive status, we used to practice like chemotherapy, but with the recent advances, we've like started using palbociclib, fulvestrant kind of drugs. So, what is your take on it?
it depends on the treatment that was offered to the patients earlier, to your patient earlier, the line of treatment, and
No, now currently, like palbociclib fulvestrant combination is approved as first line in metastatic hormone positive patients. What do we usually practice?
no, but this is as a second line. We don't use it as a first line. Like, suppose you haven't tried AI, like you postmenopausal lady, and you haven't tried AI, that has to be given first. This is what I do. If it is HER2 negative, in that case, yes, palbociclib should be added to it. Otherwise, if it is HER2 positive, then trastuzumab needs to be given, even a dual blockade. If that hasn't been tried, that and the patient can afford it, that should be done.
Yeah.
So it has
Okay.
to be a right balance. Like
There are no questions, sir. So I think we
okay,
are good to go.
so
So
okay,
once again, I would like to thank Dr. Sunil sir for his precious time, and also I would like to thank the audience today for peacefully waiting for all the technical glitches. So on this note, I would like to end this session today. Thanks to everyone present.
thank you, Aditya. Thank you,
Thank
Ankita. Thank you, everyone.